Hello, my name is Shahzad Raza. I'm one of the myeloma physicians at Cleveland Clinic, Taussig Cancer Institute, Ohio. And with me is Dr. Majid Jaberi-Douraki. He's a computational mathematician who works at the K-State Olathe. In this data, what we are going to present to an American Society of Clinical Oncology is how the drug toxicity trends varies worldwide. And this is the first of its data kind where we have evaluated the multiple myeloma regimens, its toxicities in different parts of the world, comparing to the United States. So this data does show a lot of significant heterogeneity among the different populations, incidence of cancers, incidence of drug toxicities, whether the patients are living in the United States or elsewhere. And Dr. Jaberi will talk to you about the details of that study.
Sure. Thank you so much. Hello, my name is Majid Jaberi-Douraki, and I am with Kansas State University in Olathe. And I'm leading a program called One Data, which is a combination of One Health, similar to One Health, a combination of human health and animal health. But for this project, we collect different data sets and from different regions in the world, and that's the benefits of having. But the data we having obviously has some limitations. It's not the perfect data sets, but that's the best right now available. And globally, when you look at data sets from Africa, Asia, Europe, and North America, and Oceania, and so on and so forth. So we collected all these and tried to compare them using statistical tools, and that helped us understand better the mechanisms, all the different patients behaving, the system behaving against those disease, and then using those regimens. So what we found, there were a lot of obviously differences across different regions. Some they had secondary cancers, like secondary cancers rising because of we're not sure still, because actually it still needs to do more research on that. But we found some secondary malignancy there, like neoplasms, as well as cardiovascular issues from different regions, and that was for some regions it was really high. So it means, like, for example, African Americans, they were higher death rate they had due to cardiovascular arrest, so on and so forth. And so that was the finding that we looked into that, and then we also looked at different regimens actually were prescribed and then administered in different regions in the world, and we saw some differences, and then that could be also a result of that, I would say. And then, for example, North American, they were behaving better, like against the drugs use, and less toxicities in that sense, because they were using the first, like the newest generations of the different regimens. I would probably ask Dr.
Yeah.
Shahzad to mention more about
I
that.
think it's a good data because if you can look at it, we have seen kidney cancers are higher in one region, skin cancers are higher in the other regions, and that will be presented in an ASCO meeting tomorrow. But I do feel that this data has a lot of implications that why we are seeing cardiovascular and the cardiac and vascular toxicities more in the United States compared to other regions. Is it due to different regimens or it is due to different ethnic populations? Now, in a broader perspective, our goal is to define the precision of therapies based on the adverse risk profile, like who gets the cardiac toxicities and how we can prevent those toxicities by selecting the right drug for these patients. I think there is a significant knowledge gap in that area, and we at the Cleveland Clinic and Dr. Jaberi and his team at the K-State Olathe, what we are trying to merge the clinical pharmacovigilance and pharmacogenomics all together, and basically in simple words for the patients, what we would like to say that we are actually trying to mine the data from the pharmacovigilance to pharmacogenomics to come up with an algorithm or a real scientific based approach who should get what type of treatment, and how we can improve the adverse effects profile. That's the whole goal for these abstracts.
That's exactly true. That's what we are doing. And eventually, our ultimate goal is to have this system, this platform is called IMRS, which is Intelligent medicine recommender system. Specifically, that will personalize medicine for specific subpopulations or patients that are not acting well when they go through a different, therapies. So we can offer better treatments, and hopefully that's going to have better outcomes. That's our ultimate goal. Yeah.
All right.
Thank you.
Thank you very much. Thank you.